I want to thank everyone and particularly Elisa for the invitation again to speak at this conference, and I hope that we're all together soon in the coming year. So I tried to cut this down a little bit so that we have some time for questions at the end, but I'm going to try to go over with everyone just the adrenal pathophysiology that develops with ALD and the guidance that we've put forth from the Pediatric Endocrine Society for monitoring. And then we'll talk about treatments. And then at the end, I'm going to touch a little bit on some of the concerns about testicular dysfunction in ALD. And I just remind everyone that I know most of this conference and most of the focus, rightly so, is on the nervous system impact. But for endocrine, the adrenal cortex is not insignificant. And for older men, testicular dysfunction can become a significant concern as well. So let's just kind of go through what happens. So this is my picture of, well, not mine, but the picture that I like to use of the adrenal cortex, which has 3 zones. And each zone is responsible for making different hormones that are important for function. And in ALD, those very long chain fatty acids that are getting picked up on the newborn screen, when they're circulating in high levels, tend to accumulate in the zona fasciculata and reticularis. And then this causes problems with making cortisol or glucocorticoid and androgens. And to some extent, and later on, tends to be more later on, those very long chain fatty acids can also interfere with the ability to make mineralocorticoid, which is the hormone that's important for holding on to salt in your body. And what happens is these very long chain fatty acids get into those parts of the adrenal cortex, and they start to cause problems with the cells. They lead to apoptosis or death of the cells. And they can also interfere with the hormone that primarily turns on the adrenal gland. And so ACTH cannot, which is the hormone that turns on the adrenal gland, will have trouble binding to its receptor. And then this leads to the cells atrophying and not responding well. There are also, it's important to remember that very long chain fatty acids are a precursor to the production of cortisol. And it's also thought that possibly a relatively low amount of cholesterol can lead to lower cortisol as well. So this is a bigger picture of the brain, the pituitary gland, and the adrenal glands. And normally what happens is after infancy, you develop a normal diurnal rhythm for secretion because you have normal sleep-wake cycles at that point. And the brain sends signals to the pituitary, and then the pituitary gland makes this hormone called ACTH. Typically, it's highest in the morning around 8 o'clock or so. That turns on the cortisol from the adrenal glands, and then cortisol is really important for keeping sugar levels normal in the body, keeping blood pressure normal. And what happens with ALD is the problem is that you can't make cortisol in the adrenal glands. This leads to elevations in the ACTH. And there's a loss of normal variation in ACTH and cortisol. So if you're measuring them during the course of the day, they always look the same when you lose the cortisol production from the adrenal glands. The cortisol levels get very low and the ACTH gets high. Because the adrenal glands also make androgens, you can have a very long chain fatty acids can interfere with the ability to make secondary sexual characteristics like pubic hair, and to some extent, and more common later on, salt wasting can occur also. And what does it look like? So primary adrenal insufficiency chronically will present in children as fatigue, and adults too. It's fatigue, poor weight gain or weight loss or anorexia. These kids often end up in gastroenterologist offices with abdominal pain and poor appetite, poor weight gain. And one of the classic features is darkening of the skin, which can sometimes be challenging to pick up, particularly because it's kind of slow progression. But the areas where you see the darkening typically are scars, genitals, The back of the ear is one of my favorite places to look, increases in the gums. If it's chronic and you can also have salt wasting develop, but it's less common with ALD. Acutely adrenal insufficiency is life-threatening if you don't recognize it, and it usually presents with abdominal pain and vomiting, but often in the setting of another stress, so another infection, and it can cause severe low blood pressure, low blood sugar, altered mental status, and if not recognized and treated, can be deadly. So it's really important to recognize it. These are some pictures of hyperpigmentation. These are two members of the same family. This gentleman has ALD, and you can see the darkening of the creases in his palms, the nipples. They don't have his gums, but his tongue is definitely hyperpigmented, and over the knuckles, you can see it here as well. So what do we know about adrenal insufficiency and ALD? So there are two big studies, which I've presented before at this meeting, that look at the rates of adrenal insufficiency in boys who've been seen in neurology clinics. The first study looked at boys who were followed prospectively and were relatively young and had been identified based solely on family history. And by the end of on average 2-year follow-up, 86% of those boys had adrenal insufficiency. The other study was out of the Netherlands and Boston, and they looked at the rates of adrenal insufficiency in their clinic, and they had an older group, and in that group, they had about 80% of boys and men who had adrenal insufficiency develop. The earliest report of biochemical adrenal insufficiency, meaning that this was picked up because of newborn screening and detected early, was 5 weeks of age. We think females with ALD have a low risk for developing adrenal insufficiency, so less than 1% is what's quoted. And there's no biochemical marker to predict the onset of adrenal insufficiency. So the very long chain fatty acid levels and the genes are not known to be associated with predicting when or if adrenal insufficiency will develop. So what do we do for monitoring for adrenal insufficiency? So I love to show this slide. This is one of Dr. Kemp's and Dr. Anglin's publications, and this was 2012, and it just says refer to endocrinologist, and that's pretty much it. And I want to point out how important this meeting is. This is a picture from our very first meeting, and I put in, this is when we were called the Aiden Jack Seeger Foundation at that time. But way over in the corner, you'll see Rose Marino and me, and we were the two endocrinologists in the room, and we sat there during lunch. And I think it's so important to have these meetings. But we sat during lunch and we said, you know, this is really confusing. It's hard. We're confused, and we're at two big academic centers about what to do. I think we need to get together and come up with a game plan. And so that led, the confusing parts for us were a couple, and it was, one, we didn't really understand the natural history, and I think we're still figuring out the natural history of adrenal insufficiency and ALD. But it's not as simple as just saying ACTH is high and cortisol is low during infancy, because infants don't have normal established circadian rhythms, they don't have normal sleep-wake cycles, and it's hard to predict when their ACTH and cortisol levels will be high or low in any part of the day, whereas adults, it's easier to predict that. Normal reference ranges are not available. ACTH has no reference range for under the age of 3 that's published. And in infants, cortisol levels are naturally lower than they are in adults, and most labs will give you adult reference ranges when you're looking at test results. And finally, when to start screening and how frequently to start screening was something that was definitely on our minds, and particularly on my mind, as I had a patient in New York that at 5 months of age had already had biochemical evidence of adrenal insufficiency. And so I was concerned about waiting until 6 months to start screening. So we developed a group with the Pediatric Endocrine Society, and we started to work out details, and we have published guidance that once ALD is confirmed by the metabolic centers, that we recommend referring right away to endocrinology. Personally, my goal is to try to see patients within a week. I know in some centers and some parts of the country, that's a really hard thing to accomplish with travel, but it's my goal whenever I have a referral to try to do that. And at the first visit, it's about physical exam and talking about signs and symptoms with families, all the things that I just went over with you, and just also counseling families. I think ALD can sometimes seem really scary, especially if you start Googling, but if you realize that adrenal insufficiency is something that we know how to treat and we know how to recognize, and we can save lives by giving hydrocortisone, I think that's really important for everyone to get that message. So I try to get that message across at the first visit. And then in terms of when to start screening and how often, based on several of our experiences, we decided that we would start early as soon as diagnosis was confirmed. And with the younger kids, do a little bit more frequent screening, in part because it's very difficult to make the diagnosis during infancy, and because we don't really fully understand how quickly it can develop. I will say these are things that we want to answer the questions to. And then I always emphasize parent education and going to websites and making sure families know that they're not alone, that there's a whole community of physicians and parents and researchers out there to support them. Under the age of 1, because the diurnal cycle has not developed, I offer to families to do a stimulation test instead of having them come back if we get equivocal results. Usually by the age of 1, assuming they have somewhat established sleep-wake cycles, we can start doing tests at 8 a.m. But then we do recommend doing stimulation testing if their results are coming back equivocal or not clear. And then to start treatment when the test results indicate that adrenal insufficiency is present. This is a big slide and a lot to look through, but you should just know that there's an algorithm out there for any pediatric endocrinologist who is seeing children with ALD, and for parents who are on this call, I would just encourage you to make sure that your endocrinologist has access to, this is an open access article that they should have access, be able to reference and be able to look through. And I want to point out that I think it's clear that the newborn screening is identifying boys early, and because adrenal insufficiency is difficult to diagnose and can be missed, I do believe that it's saving lives. This is a publication that one of my fellows and I wrote a few years back of 2 of the younger kids in the early few years of screening that were detected to have adrenal insufficiency, and both have been well managed in terms of their hydrocortisone. And I also found a publication from California. I don't know if any California people are on this early today, but California also pointed out that they are finding kids who have adrenal insufficiency early on as well. And this is just a publication that they have from the first few years of screening in California. And you can see that they're starting to detect boys at a young age with adrenal insufficiency who are getting treated. It's not a huge percentage, but detecting early and starting treatment early does prevent significant consequences when they have infections or need anesthesia. So that's great. So what do we do for treatment? Treatment for adrenal insufficiency is pretty much standard, whether you have ALD or you have another cause of adrenal insufficiency. For children, we give hydrocortisone. It comes as tablets, and more recently, there's a sprinkle preparation. It's given 3 times a day. And parents and caregivers need to be trained in how to give extra doses when a child is sick, and be trained in the emergency use of injectable hydrocortisone as well. And then monitoring for salt Salt wasting should occur every 6 months, once on hydrocortisone. Adrenal deficiency is controversial, whether or not to manage or treat. Generally, most academic endocrinologists are not going to treat the adrenal androgen deficiencies. For long-term follow-up, patients who are treated with steroids need to be monitored carefully for growth, making sure that they're growing steadily, making sure they're not getting too much. If you get too much, you can start to have problems with blood pressure and blood sugar and cholesterol. And I would just remind everyone, including the neurologists in the audience, that hydrocortisone is a medication that can be altered by other medications. So anytime there's a new medicine added to a child's regimen, it's important to look for drug-drug interactions and make sure that the hydrocortisone is not being metabolized faster or slower. Patients should all be given some form of a treatment plan. This is a published treatment plan. I have a slightly different one that I give to patients in the office, but it should give them a plan for what to do when they're healthy, what to do when they're sick, what to do when there's a severe emergency, and what to do before surgery or anesthesia. And safety is important, so we always tell patients to wear medical IDs. We make sure everyone who's taking care of them knows how to treat the extra hydrocortisone. And I always suggest having an emergency kit or a go bag that is at school, that's one at home and one at school, so that if ever you have to go anywhere, it has the emergency medicines, some of the tablets, as well as the action and emergency plans. And I do give parents also emergency care letters that they can take with them to any emergency room. So I grew up in a really rural area. So if you have to go into urgent care or a small hospital in the middle of nowhere where I grew up, you can literally hand this paper to the physician in the emergency room, and it gives a recipe for how to take care of the child with adrenal insufficiency and all of our phone numbers so that they can reach us and talk through everything else after that. And we know that planning and it does prevent complications. This is a publication out of Minnesota where their anesthesiologists have a protocol for hydrocortisone replacement. And this was specifically for ALD patients, and they reported no significant events with 166 anesthesia encounters, which is wonderful. And I just briefly would just touch on Lorenzo, some of the investigational therapies. So there's a small open label study using Lorenzo's oil that suggested that maybe it would slow down the progression of adrenal insufficiency. It was a very short time frame for that trial, and I would be cautious to say that that would slow it down. It definitely did not revert, Lorenzo's oil did not reverse adrenal insufficiency once it was already present. And then stem cell therapy has not been shown to reverse adrenal insufficiency or stop the progression of it. And it's assumed that gene therapy will be the same, although no publications as of yet for that. And then just briefly, I just wanted to mention testicular dysfunction because it does come up. And I will say it's more common in adults, and as a pediatrician, I don't see it as often, although sometimes with adolescents, it's a concern and we discuss it. There are very few studies. The studies that were done more than 2 decades ago, and when we had different assays for testosterone, but the studies that are out there suggest that possibly up to 3/4 of adult men with ALD will have some form of biochemical testicular dysfunction. And it's assumed that those very long chain fatty acids interfere with the cells that produce testosterone in a similar fashion to the way they interfere with the adrenal cortical cells as well. And the main concern with androgen deficiency or testosterone deficiency is a decrease in bone mineral density. It can lead to anemia, increased body fat, depression, and decreased libido and decreased spontaneous erections. The studies that were done, again, these are older studies from the 90s, when it may not have been as easy to talk also about erectile dysfunction as well. But again, men were reporting, about half of men were reporting symptoms. And when they did blood tests, they were finding significant biochemical evidence of low testosterone for several of them. And very similar biochemical evidence, it was at 80%. Again, I would caution that these are older laboratory assays, but again, about half of the men were reporting some symptoms as well. And this is a crossover trial where they actually replaced the DHEA, which is the hormone that the adrenal glands make. They did not find a significant change in very long chain fatty acids when they did this, but it lowered some of the essential fatty acids. And because of safety concerns, the trial was stopped. And this is the main reason why a lot of endocrinologists shy away from using DHEA supplementation, even though we know that it's deficient. It's because it clearly impacts other things and has concerns for cardiovascular disease. So just to summarize, ALD newborn screening is definitely identifying boys who are high risk for life-threatening adrenal crisis. Our guidelines try to predict, help with interpretation of ACTH and cortisol during infancy. And while we don't fully understand the natural time course, again, I do think that we're picking up early and helping prevent adrenal crisis. And I think it'll be important to have long-term follow-up studies from newborn screening. And there are very few reports on testicular dysfunction in ALD. And so I think this leads to what we need to consider for the future. And for adrenal insufficiency, I think collaborating with newborn screening programs for long-term follow-up is going to be important. And helping to identify biochemical markers that would predict adrenal insufficiency, I think will also potentially help us with determining how often to screen and when to screen. And eventually revisiting the guidelines that we published, I think will be important. And then I think adult studies are needed for determining testicular dysfunction risk and how best to manage it. I think there's also a lack of follow-up in the adults with AMN with bone health concerns. And then finally, I think doing research on females who have ALD and determining their risk of adrenal insufficiency would be helpful. Currently, the recommendation is only to test if symptoms appear. And I just want to say thank you to everyone. And I really mean this, everyone. Elisa and Miranda, this is a great conference, even though I know it's virtual this year again and not where we want to be. I'm really happy to be part of this community. And I really appreciate all the patients and parents and all of the collaborators as well.
Thank you so much, Dr. Regelmann. We do have.
I gotta get to the chat.
Oh, okay. Yeah, I'm happy to read them to you. I have one, and then we just got one, so I'll read this one from Susan. Once children with AI start on hydrocortisone, does it arrest the development of hyperpigmentation and other symptoms of adrenal insufficiency, or do the symptoms still appear?
So the hyperpigmentation usually gets better. Most people who are requiring treatment with hydrocortisone are not going to have their ACTH values completely suppressed, and you don't want to do that, because if you get the ACTH values completely suppressed, then usually you end up with some of those side effects we talked about, like not growing well and high blood pressure. So usually most kids will have and adults will have sort of a nice bronze tone to their skin, but they will not have as dark a skin as when they're initially diagnosed. Now, that's someone who has full-blown primary adrenal insufficiency when they're diagnosed. hopefully with newborn screening, we're catching it relatively early. And so it's not quite, the skin's not quite as dark, hopefully, when we're first starting. The hydrocortisone doesn't, starting hydrocortisone though doesn't stop the natural progression of adrenal insufficiency that's occurring with ALD though either.
Thank you. My question is with regards to the families that have the kiddos that are in this 5 to 11 group that are now, many are seeking the vaccine. I have this thought because my son just had his second dose a few weeks ago, and now we're due for our routine blood work. And I have this thought, should we be careful with our timing, especially for the kids that, are, maybe screening more often than that? Do we have to worry that that might influence our lab results, or?
I don't think so. I mean, if you're actively having a reaction to the vaccine, so there are two things. Number one, please vaccinate. That is the number one way to prevent your children from getting severely sick. And we do know that primary adrenal insufficiency is a risk factor for progression of COVID symptoms becoming more severe. It's adult publications, not pediatric publications, I will caution, but we know that vaccination prevents progression to severe disease, so please vaccinate. But unless you're having a reaction after the vaccine, so if you're actively having muscle aches after the vaccine, I don't anticipate that the ACTH or cortisol would be impacted otherwise. And it would be like actively at that moment. If it happened a week ago and then you go in for your labs, it really shouldn't be different.
Thank you. That's good to know. I don't see any other questions in the chat, but I am noticing some people have turned their camera back on. Are there any other questions for Dr. Regelmann before we switch to neuro?
I'm on the chat all day too, so I'll take a look too.
Thank you for that. We appreciate it.